multimodal way for maybe close to 10, 20 years now. These are my financial disclosure. As you know, as retinologists, we are really blessed with many types of retinal imaging that can give us information of our retina in various different ways. So you can see here ICGA, OCT, autofluorescence, fundus fluorescence, and multicolor imaging, etc. Now, today's practice for wet AMD, for example, we depend a lot on visual acuity and OCT for our diagnosis and for decision making and for follow-up. So most of the clinical decision, as you see, a standard case of wet AMD would be OCT based. So it's almost monomodal. So you may ask, what is the role of multimodal imaging? Is there still a role? So I'd like to just share with you some facets of multimodal imaging and start off with some basic principle. And then I'll take you through some cases to look at the use cases that multimodal imaging can help us in our day-to-day clinical practice. So first, fluorescein angiogram, which I believe most of us here are familiar with. Now, one key point about fluorescein imaging is that it is an indirect imaging of the wet AMD pathology. Why? Because it is 80% protein bound, and therefore it leaks quite rapidly outside the blood vessel, and therefore enter the interstitium and then enter the RPE cells. So fundus fluorescein angiogram is very good for anything above the RPE. It's good to outline the retinal vasculature, but when you come to choroidal vasculature, then it is not so clear. The second important concept of fundus fluorescein angiogram is that because it leaks, therefore you can use the leakage to our advantage to tell where the leakage areas are. Therefore, it is an indirect way of imaging wet AMD. So take, for example, this case. Now, can you see my cursor? Now, this is fundus fluorescein angiogram early, typically is about 1 minute, and then late, anything from 10 to 20 minutes after injection. Fundus fluorescein angiogram is typically read in a pair, starting with early and then the late frame, so that we can track lesion to lesion. Now, if we look at the lesion here, right here, and compare it to, say, 10 minutes later, you will see that the border has increased a little, but it's largely the same. So this is just pooling with a bit of staining, compared to the whole area here, which compared to 1 minute is almost the same. So this is actually window defect for most of the area here. But if you look at this area, temporal to the disc, then you see that the dye leaks and it is brighter, hyperfluorescent, and the border is also fuzzy. So it is a sign of leakage. So when we read fundus fluorescein angiogram, look for leakage so that you know where the trouble spots are and also where it is actually not leaking. So those are not the trouble spots. Now, what about ICG angiogram? Now, ICG is 98% protein bound, therefore it stays intravascular a lot longer. And because of that, it is very good for outlining the vasculature of the choroidal circulation. The second point is that the ICG not only stay within the vascular because it is imaged by infrared, so it can reach deeper underneath the RPE. So it is very useful to image choroidal vasculature and choroidal new vessels that's lurking underneath RPE. Now, take for example, this particular case, this particular picture show us that Or the choroidal vasculature is actually quite nicely imaged by ICG. However, there are different types of ICG angiogram. From the left, this is imaged by a flash mode of lighting. In the right is confocal scanning laser imaging. So if you employ confocal aperture, the contrast is much better. And if you add in scanning laser method of lighting up the retina, then it reduces glare and therefore allow us to image the blood vessel with exquisite detail. Now, if you look at this particular case that we showed earlier, this is FA early and FA late. But if you image with ICG, you can actually see the vasculature underneath the RPE causing the pathology. So you can see that the area corresponding to the leakage, actually it is type 1 on CNV right here that is very active. And on the other side, you can see that there is polypoidal lesion here, but this polypoidal lesion is not leaking. So the polypoidal lesion right here is not the troublemaker. The troublemaker is the CNV right there that is creating leakage and exudation. So for example, this patient would just need anti-VEGF treatment. And if you can, just use laser to photocoagulate this polypoidal lesion. So we can then tell us where the problem, the troublemaker is, and treat accordingly. Now, if you juxtapose this to the FA, you can actually see how it lined up very nicely. You can see the lesion. Sorry, I'm trying to show you the lesion if we juxtapose it. Okay, you can overlap the image and see how the image line up. Okay, you can see how the image line up very nicely. Okay, now this is another case, another example. You can see that this is ICG case of typical polypoidal choroidal vasculopathy case. However, when you see the polypoidal lesion here, you can't tell based on fast imaging at which level it is. Right? Is it sub-RPE, above RPE, etc.? Now, if you co-locate it with OCT, then you can see that there's nodular hyperreflective lesion OCT that is underneath the RPE. And you can correlate with the image you see earlier, right here. And this lesion is actually this lesion right here. So it corroborates with your finding against one modality to the other. So giving you very clear certainty that you're dealing with a PCV lesion. Likewise, you can see that this is PD right here, and that corresponds to this hyposinusant area right here. And dome-shaped lesion in confocal scanning laser usually appear hypofluorescent due to total internal reflection differences. Now, what about another mode of imaging, OCT angiography? So with flow signal, we can actually use OCT technology to image the vasculature. Now, this can be used to detect polypoidal lesion, as in this case, ICG angiogram show a polypoidal lesion and OCT angiogram show the corresponding lesion. However, it is not as sensitive as ICGA. So about under 80% of polypoidal lesions are actually imaged on ICGA. You might miss north of 20%. In some studies, actually the detection rate per polypoidal lesion is as low as 20%. However, OCTA is very good at imaging the branching vascular network or the type 1 CNV. In particular, it is very useful to detect type 1 CNV in cases of very thin pigment epithelial detachment known as double layer sign. And this is very common in cases with pachychoroid and in cases of CSCR. Now, the important concept of OCTA is that although it is imaged with flow signal, it is actually a structural imaging. It doesn't tell us the flow unless you are using some advanced machine that has got, for example, Vista sequence. Now, majority of OCTA basically tell you the structure, and you can compare this to ICG angiogram. Now, important concept of OCTA, it works if you segment it correctly. So for example, in this case, you can see that this particular image look as if there's polypoidal lesion right here, but if you segment it correctly, actually it is not. And the polypoidal lesion disappear. It's because of artifact due to wrong segmentation. Now, it is a structural imaging and akin to ICG angiogram, and oftentimes you can actually juxtapose it and it looks exactly the same as your ICG angiogram. However, there are cases that ICG angiogram can't image the vessel or the vasculature of type 1 CNV very clearly, and OCTA can image it very well. And there are cases that are actually the other way around. You can see the ICG angiogram. But perhaps because of slow flow, it doesn't light up or doesn't show up in OCTA that well. So they are complementary, right? If you see both type of modality and you compare and you say, okay, I can see this structure here, and you compare with the ICG angiogram, then you can say that with certain degree of certainty that we are dealing with type 1 CNV right there. Now, all this is possible if you have a machine that does co-location very well. So an example is Heidelberg system. There's a dual laser tracking machine so that every image can be co-located across different modality. So in summary, multimodal imaging works to complement each other. It also works to corroborate the evidence we see, and both are done through co-location. So now let's go through some cases to see how multimodal imaging, especially looking with co-location and comparing across modality, come alive in day-to-day clinic. So this is a patient with subretinal fluid that actually has received 4 aflibercept injection and not getting better. Now, from this OCT, we can see why the patient was treated with injection. As you can see, there's a vague double layer sign, bit iffy, and there's a little PD here, which may suggest polypoidal choroidal vasculopathy. Now, this is monomodal imaging, right? So after 4 earlier injection, it didn't work. And then, therefore, we go on multimodal imaging. So OCTA, which is very good for looking at those thin double layer sign to look for CNV. After proper segmentation, there's actually no CNV there, right? And if we look at ICG angiogram, you can see these areas of hyperpermeability. And one way of looking at ICG to say that this is hyperpermeability is that you look at 3 minutes after injection of ICG, and you start to see that you can't see the larger choroidal vessel, right? You can see the larger choroidal vessel here, but not here. That means there's leakage obscuring the larger choroidal vessel. Now, therefore, this patient looks like having CSR, right? And if you look at FA, that more or less confirms the diagnosis. By looking at early frame, you can see pinpoint hyperfluorescence right here that then go on to leak as an ink blot. And there's another pinpoint hyperfluorescence there that leaks over here. So this patient basically just received a small spot of focal thermal laser right over here, or if you like to, you can treat with PDT, half dose PDT. Either way is fine. This patient just received a small spot of focal laser, and the subretinal fluid disappeared. This is another patient that has similar case history. Another patient who has received 8 ranibizumab injections came to see us, and we can see why the person received this because of this PED. It's not a serious PED, but look at this internal hyperreflectivity. And this patient, after receiving multimodal imaging, it's amply clear that this is a spot of pinpoint hyperfluorescence that leak into ink blot. And this patient just received PDT and the lesion resolved. Another patient already lost one eye through wet AMD and disciform scar in the right eye. An elderly lady came to see us with this lesion in the other eye. You can see subretinal fluid, serous PED, and the patient underwent multimodal imaging. ICG actually showed some nodular hyperfluorescence. So we start to scratch our head, are we dealing with polypoidal choroidal vasculopathy or not? Late phase ICG angiogram did not show hollowing out of the dye here, which a polypoidal ought to show. And so we look very carefully at the OCT, cross-checking exactly where the nodular hyperfluorescence is between the two serous PED. Now, if you look at this particular section of OCT, you can see that between the two serous PED, there's actually no elevation, right? There's actually no PED. So that tells us that this patient is not having polypoidal, right? But having CSR. So this is confirmed with FA, where you can see a smokestack lesion right here. So this patient just received half dose PDT covering the wide area, and the subretinal fluid disappeared, leaving behind serous PED, which subsequently disappeared. This patient was followed up more than 9 years and did not have any recurrence, did not need any injection because it's a CSR that's properly treated. So the first role of MMI or multimodal imaging for wet AMD management is actually differential diagnosis, in particular, right, looking for CSCR and to guide treatment for central serous chororetinopathy. Another case, this is an elderly lady, right, that presented about 3 years ago with left AMD treated elsewhere, so we don't know the subtype of wet AMD. Was treated with Eylea, initially resolved, stopped, and then went on PRN regimen. A year later, recurred, treated with 7 injections of Vabysmo, and then went on to Eylea 8 milligrams, not responding at all. So sought second opinion, and this is the patient's fundus photo. You can see outline of a PED right here and the old laser scar right here. Now this is serous PED on the OCT with some subretinal fluid at its peak and this valley. Now in another section on top here, you can see double layer sign. So we are saying, hey, this may be CNV or polypoidal. So we went on to do the FA, which showed pooling as what we would expect. And ICG showed that there's a 2 little polypoidal lesion and a network of vessel here, branching vascular network. So indeed, this is polypoidal. This patient received treatment. After treatment, we just call it treatment X. Yeah. After treatment X, you can see that the serous PED disappeared. and there's no more subretinal fluid. Went very well. That was 2025 December. Now, just for a poll, yeah, what do you think treatment X could be? Right? Is it Vabysmo again? Is it Eylea again? Is it, we switch to Lucentis maybe, yeah? Or is it Metoprolol PDT with anti-VEGF or thermal laser, right, combined with anti-VEGF? So please go ahead and give a poll. Now we wait for our cyber colleague to give a poll. So please feel free to click the one that you think the patient had received. Yes, oftentimes no right or wrong, just to share what this patient actually had received. So if you see a patient like that, what would you use for this patient? Yes, so very good. So exactly, because the patient had quite a number of injection and didn't work. So giving injection, continued injection is fine, just that the chance of responding will be corresponding lower. And many here mentioned Metoprolol PDT, which is a good choice. Yeah. And a few mentioned thermal laser. I am actually very pleased that 30% mentioned thermal laser. So not every case you need to use Metoprolol. Yeah. So let's advance the slide. Here we are waiting for the slide to spawn again.
Hi, Professor. You may need to click on the presentation again.
Okay. Yeah. Okay, we got it. So indeed, this patient actually has received focal thermal laser without PDT, and then the patient did very well. There's no recurrence after 31 weeks without additional injection. So therefore, a role of multimodal imaging is for non-responder or patient for some reason didn't respond. Actually, a lot of patients would respond to Vabysmo or Eylea or Eylea 8 milligram for PCV patient, but this patient unfortunately did not. But somehow he responded very well to focal thermal laser. So another case, yeah, it's a fairly young patient that has left metamorphopsia, was diagnosed with AMD elsewhere, was given Avastin times 6, Eylea times 2, and referred in for an opinion. This is what patient showed in 2020, October. That's probably in the midst of COVID. OCT, monomodal imaging, show us double layer sign right here and a peak PED. So we all expect that to be a polypoidal case. And indeed, ICG did show a polypoidal choroidal vasculopathy, branching vascular network here, and a nodular ICG hyperfluorescence with a rim or hypofluorescent rim. So it satisfied the Everest criteria. So in 2020, what we gave this patient Metoprolol PDT in combination with anti-VEGF treatment. And it settled down for a while, but another peak PED appeared, and then some more PED appeared, and then submax hemorrhage despite well treated with combination therapy. And then a third PDT, and after that, we start to see quiescence, and then all we are left with is a very shallow PED or double layer sign. And you can see that I dare not stop anti-VEGF, but extend the interval to 6-month interval. So this patient is now under control with just 6 monthly injection, and so far has not recurred. Now, why is it important to make a diagnosis of PCV. A very important concept is the treatment aim of PCV is not just quiescence of the maculopathy, it's not just visual acuity gain, but is complete polyp regression. Now, this is an example that if I don't destroy the polyps, it keep coming back with submac hemorrhage. There's a subgroup that's very, very active. And there's a paper by Cho et al. That's followed up 200 over patients with PCV and look at the relative risk of recurrent submac hemorrhage over 11 years. And the incidence rate of massive submacular hemorrhage at 3, 6, and 9 years, actually comparing with complete polyp regression and without complete polyp regression is a world of difference. So you can see at 3 years, if you have complete polyp regression, you're at 1/6 the chance of getting a recurrent submacular hemorrhage. Yeah, at 6 years is 1/4 the chance, and at 9 years is still 1/3 the chance. So therefore, increasingly, many people who treat polypoidal then feel that complete polyp regression is an important treatment endpoint. And so with multimodal imaging, it helps us to see whether there are residual polyps, and we are able to then be very sure that we have destroyed all the polypoidal lesions. So another case. Now, this is a patient with PCV, but interestingly, that the serous PED right here is caused by a giant polypoidal lesion. So let's see the ICG. Yeah, you can see that here is the branching vascular network, very thick vasculature. But if you put a cross section across the branching vascular network, all you see is the double layer sign. You don't see any exudation. So it's a very mature type 1 CNV. And at the edge of the type 1 CNV, you see that there is a bunch of grapes of appearance of polypoidal lesion right here. Now, this patient, if we treat with original Everest protocol, you have to treat the whole lesion. With Everest 2, actually it tells us all you need is to target a polypoidal lesion and destroy it. So this patient actually received a few PDT session combo, and it finally reached resolution, right? There's a slow collapse of the polypoidal lesion and resolution of the serous PED. And this patient went on to remain quiescent for the next 9 years and started recurring only 9 years later from the branching vascular network. No new polypoidal, and we just treat with anti-VEGF treatment once in 4 months or 6 months. So for 9 years, no injection needed. Some more cases. Another patient, this is actually one of the Everest case, or rather Everest 2 case, yeah, exudative maculopathy, as you can see here. OCT showed peak PED, round hyperreflectivity. This is fairly typical of PCV, yeah? And you can see subretinal fluid and it's double layer sign adjacent to it. So just by monomodal, you can say this is likely to be polypoidal. And of course, ICGA did show it, but multimodal imaging allow us to target the lesion very well. You can see the lesion outline in yellow and the PDT treatment zone in green. So this is an Everest 2 case. 2 years later, at the end of the trial, of course, we then open label. We know that this patient was treated with combination therapy, and the patient was 20/20, right, despite having PDT over the fovea. And the patient is quiescent, and the patient stayed on being quiescent from 2016 to 2023. So that's about 7 years. again, no injection, and then started to have a recurrence at the edge here. And we did ICG and showed that there are two new polypoidal lesions right here, which are very nicely treated with just focal thermal laser. But to be safe, I added Lucentis. And the patient since then has been quiescent for the next 2 year plus, 2.5 years, no further injections needed. So that shows that combination therapy in polypoidal case, if you have the benefit of multimodal imaging targeting, you can actually achieve quiescence for a fairly long period of time. And Everest study, or Everest 2 study, did show that PDT in combination has better visual gain compared to ranibizumab monotherapy and has got higher polypoidal closure rate, close to 70%, requiring only about a median of 2 PDT injection. Now, there's new study, Salwin study, which just been presented in the last year or so, showing very good polypoidal closure rates just by using Vabysmo monotherapy with closure rate of 61%. That's very close to PDT combination therapy. So that actually gives even more treatment options. And for places that you don't have multimodal imaging and have access to Vabysmo, Vabysmo would give you fairly good disease control. And if you have for any reason, in the other 40% that you have still open polyp, then yes, do consider multimodal imaging and see whether additional therapy can be beneficial to the patient. So multimodal imaging for polypoidal give you alternative treatment possibility using PDT combo or laser treatment. Now, another case. This patient is a 69-year-old male, history of glaucoma, and incidental finding of non-exudative CNV rather, some 11 years ago. So this is the fundus photograph showing some mottling of the macula, and monomodal imaging, OCT showed double layer sign. OCTA showed you CNV. These are the non-exudative CNV and can just be observed, no need to treat with injection. And this patient was followed up for 9 years, right, before it started to turn active. Yeah, you can see a bit of subretinal fluid. You can see also thick choroid, pachychoroid. And when we image with OCTA, then showed round area here, which highly suspicious of polypoidal, went on to do ICG to confirm the diagnosis. Now, this patient was treated by Eylea injection, treat and extend regimen. You can see with a number of 6 Eylea injections, you can see that this area of polypoidal lesion had resolved, but this one did not go away, right? This is a recalcitrant one. So this patient went on to receive more injection, but at some point, the patient has expressed treatment fatigue and wishes to stop treatment because he's flying in and out from overseas and find 2 monthly flying into Singapore with injection very disruptive for his lifestyle, and he wanted to stop treatment altogether. So what I suggested to him is give me one last chance. Yeah, I would recommend treatment Y and see whether it will help him with fewer treatment burden and longer treatment interval. So this patient then received treatment Y. In every sense, he's doing very well with 2 monthly Eylea injection. Yeah. 1 month after treatment Y, you can see here the lesion has disappeared. The 2-peak PED has resolved. Just compare with February, and then you look at after treatment, right? It has resolved. And what could treatment Y be, right? Again, feel free to poll. Did we then use either 8 milligram by Vabysmo or verteporfin PDT or focal thermal laser? Yeah, feel free to do your poll. Then we can see what everybody thinks. Okay, I think the polls are coming in. Okay, yes, so I think 40% mentioned verteporfin combination therapy, and that's exactly what the patient received. The patient actually could have received Vabysmo, right? Because the response rate to Vabysmo at that time had just coming out from in a conference, not so clear yet in 2025, but right now we know that Vabysmo response rate is 61%. So the patient actually could have received Vabysmo, but still would need at least 4 more injection before we can extend, and he will still have to travel back and forth for quite a number of visits. So at that time, before the patient give up on me, I thought maybe we pluck up the courage to do verteporfin PDT combination. So this is what we did. But important point is that the patient actually is in a quiescent stage. So it's very important not to overtreat this patient. The patient actually had half-fluence PDT using overlapping treatment spot to avoid irradiating the fovea. So the patient was quite fortunate that has got very good response, and then went on to, we are able to extend treatment interval quite a lot. I believe the last count was that he's sort of flying in every 6 months just for the injection. Quite important is that treatment fatigue is a real issue. In this study, about 30% of patients receiving wet AMD treatment by anti-VEGF treatment actually has treatment fatigue. And there are many causes of treatment fatigue. But of course, short interval and travel and difficulty in getting appointment, etc., add on to the problem. Yeah. So there are alternative therapy that could potentially have longer durability, and we also feel that if we have multimodal imaging, we may be able to propose alternative treatment for those few cases that require very frequent injections. So another case, yeah. So this is a patient that show up with this PED right here with round hyperreflectivity, and we suspect that this patient has polypoidal, and indeed you can see branching vascular network polypoidal lesion, and this patient received verteporfin PDT right here, and you can see that we actually did not irradiate fovea, right? So there's extra foveal treatment. The patient responded to treatment, but notice that there's now subfoveal PED. When we do ICG, you realize that the original branching vascular network is here, but there's a new branching vascular network over here. So the patient actually has 2 CNV. And this patient then went on to receive many Eylea injections in a treat and extend manner. At some point, we started to realize that the patient is developing this area of geographic atrophy in the infrared imaging. And you can see it even clearer now. And over the years, although it responded very well to Vabysmo, the patient continued to have enlargement of geographic atrophy. So multimodal imaging can be useful to pick up areas of geographic atrophy, or in fact, we should call it macular atrophy in the context of wet AMD. You can see this first appearing here in 2017, and then it start to enlarge and keep enlarging relentlessly. And this is another mode of imaging, which is on fast OCT. You can use dense scan OCT or at least 97 sections in the central 25-degree, and you can then reconstruct the OCT using on fast imaging, and you can see the enlargement of the macular atrophy right here over the years. And you can use that to monitor and also warn the patient for future visual loss. And whenever I see area of macular atrophy in the context of wet AMD, I will start to push for longer interval as long as I can. So in macular atrophy, it's actually very common, right? Grunwald has shown that the cumulative incidence was 12% at first year, 17% at 2 years, and 38% at 5 years. So it's a real problem. And if we do not use the multimodal using autofluorescence imaging on fast OCT, the lesion will sort of creep up on us. And when the patient start to lose vision, we may look back and say, oh, no, I'm seeing this lesion for the last 5 years, 10 years, and we may not have warned the patient of visual loss. So at least there's one more role of multimodal imaging, and that's to monitor for macular atrophy. And I hope these few cases show you that the retinal imaging world can be accomplished with more information and more treatment possibility and monitoring possibility with multimodal imaging rather than just using OCT alone. Yeah, granted that most cases you do very well with just OCT, but when things don't turn out the way you think, feel free to pull out your old FA machine and ICG machine. So thank you very much. So yeah, let's go for Q&A. So we still have about 14 minutes. We could take some questions. So let me find out how to click the share button. There we go, Q&A. Yes. Okay, we have some questions coming in. What's the clinical connection between glaucoma and major depressive disorder or other neurological condition? Yeah, unfortunately, I don't have the answer for this very important question. Probably need to read up. Yeah, what specific structural biomarkers in this OCT cross-section point directly toward your diagnosis over other differential possibility? This is a question from Hina. May I know which particular case that is that you're asking about? Yeah, perhaps we wait for Hina to type in, then we go to another question first. Yeah. Ukba, hi, how are you? Ukba from Pakistan. You have a question, why neovascularization show leakage, but normal vessels don't? Yeah, so neovascularization, they are in a way further common immature vessels. They don't have structural integrity in terms of endothelial tight junction, and also a lack of parasites. So that's why they leak quite a lot. So they don't have the regular blood retinal barrier. So the next question is, in which retinal condition is FA still preferred over OCT? And when would you choose one over another? So I would say the mainstay of retinal imaging, managing patients with CNV, PCV, CSR, RAP, etc., is still OCT. But there are cases where OCT alone don't give you all the information. And when you feel you need to use other treatment modalities, then FA come in. In cases that's not responding well, poor response, or you have doubt in diagnosis, that's where FA come in. Could you please explain what double layer sign is? Yes. So our RPE reflection line on the OCT actually up the base Brooks membrane reflection line. So usually you can't differentiate, or you can't see two layers. You see a single layer of RPE reflection line. But if there is tissue between the RPE and Brooks membrane, in many of these cases are type 1 CNV, then the RPE, you can see a distinct reflection line as in RPE, then there's a gap, and then there is Brooks membrane reflection line. And that's what we call double layer sign. Now, unfortunately, double layer sign is also very much an abused term, right? Because there are obvious cases of PED, and they are very far away from the Brooks membrane, but they also describe as double layer sign. But it typically, if the RP is just lifted away from the Brooks membrane with a very small gap in between, that's a typical double layer sign. And OCTA is very good at characterizing it. Next question. Do you perform modified PDT for PCV cases as a thin choroid? Okay, yes. Would you give half dose verteporfin or reduce fluence PDT, or reduce both dose and fluence? Okay, I have a PCV case with choroidal thickness 121 micron that's not responding to monotherapy. What would be the best choice of PDT? Yes. So it is a prudent thing to go easy with your PDT if your choroid is very thin. Having said that, 121 micron is not too bad. Yeah, it is actually quite decent thickness. You can attempt to do foveal sparing PDT. And if you can truly treat a substantial portion of your polypoidal lesion when it's away from the fovea, then I will go for full dose, full fluence. Yeah, because if you go for half fluence, I don't find it as reliable as full dose, full fluence. Now, for me, if I need to moderate, there will be cases where, yes, the choroid is thin. Two, I have to irradiate through the to the fovea. Third, if I need to do repeat PDT over the fovea, then I will be very careful. I will use reduced fluence, and later I'll share with you the two ways of doing reduced fluence. And an additional indication for reduced fluence is when the fovea is very dry. That means there's hardly any fluid. Usually under 100 micron, I will go very carefully. I won't use full fluence, right? So for reduced fluence, you can either reduce the fluence itself, or you can reduce duration. So if you use half duration, you have a similar effect as half fluence PDT. You can also mix and match, right? So you can irradiate a larger area with half duration, but focus the remaining duration on a specific area, for example, a giant polyp or giant polypoidal lesion, that you require full fluence treatment over that area. And then you avoid the full fluence over the fovea, but at least you have some irradiation over branching vascular network. So that's what I would do. Okay, next, difference between thermal laser and micropulse is okay. So thermal laser is continuous, not by pulsing, right? So micropulse laser is to use a very short pulse repeatedly that can then reach deeper tissue without heating up the RPE. So the idea is to deliver most of the energy in a sub-RPE manner. And or you can use micropulse to stimulate some functions of RPE. So when you use micropulse, there are actually two aims. One is to tickle the RPE to create the bio effect on the RPE. So the understanding is you tickle the RPE using micropulse, usually it's sub-threshold, you don't see a burn. You would then release cytokines that are by nature anti-VEGF. So that's one way of using micropulse. The second way of using micropulse is actually to deliver energy underneath the RPE without heating the RPE enough to cause retinal opacification. Right? The thermal laser is opposite. Thermal laser, you want to heat up the RPE to a temperature where there is photocoagulation. Right? So the tissue that absorbs the thermal laser burn is RPE and or the hemoglobin within the blood-filled vasculature. So let's say if you burn a polypoidal lesion, you're actually lasering, heat up the hemoglobin within the polypoidal lesion that cause coagulation, and then you cause photothrombosis. Right? That is thermal laser effect. Now, if you treat with thermal laser for CSR, you are actually just using very light laser on the area of RPE aperture that is leaking fluid from sub-RPE lesion to the subretinal lesion. So you find that spot, right, the pinpoint hyperfluorescent spot, and you deliver a very light laser there, just aiming for a light burn. Yeah, that's all you need. So that is for different mechanism of action. Okay, next question. Sorry, I have moved down too fast. Okay, this is a question from Hafsa from Pakistan. I'm a bit confused about this point. Could you please explain whether a repeat ICG angiogram is needed to monitor the treatment response, or if OCT follow-up is enough once the diagnosis is confirmed? Okay, so if you have a patient with polypoidal lesion, aim of complete polyp regression is important one. So by right, you should do check ICG, right? When you monitor with OCT until most of the lesion has resolved, then you do a check ICG. If check ICG you don't see any nodular hyperfluorescence, then you say this is complete polyp regression. Now, however, pragmatism prevails, yeah. So if you treat the patient, whichever means, yeah, and you find the peak PD is gone, the RPE is sort of flattened, and there's no more activity, then a lot of time I don't do check ICG because most likely there's nothing there, right? But if there's any doubt, right, you still see a small peak PD that's reduced in height, but nevertheless still there, then I would do a check ICG. And time and again, it helped me, right? And to sort of decide when I'm going to see the patient again. And I've had bad experiences when I didn't do that. And the patient then went on, for some reason, didn't come back for treatment. And then you see a bad submax hemorrhage later. Okay, next question is from Barmax. In my French African country, we don't have ICG and PDT, just FA, OCT injection. Therefore, is it easy to always manage like that? I would say large majority of patients you can just manage like that. FA would have help you diagnose quite a number of CSCR patients as well. Yeah, and if there are remaining cases, the good thing is that now the newer generation of anti-VEGF, they are pretty good. Whatever treatment subtype, you can treat very well. So I think the number of patients that you find that you can't treat, right, the really treatment resistant cases are not that many. Right? In those cases, you might have to think about referring, or you might have to do some FA guided treatment. Thanks. Or FA guided thermal, since you don't have PDT. Yeah. Next is I have two questions from Samoa. So nice to meet you, from our friend from Samoa. Which clinical scenario would verteporfin PDT combined with anti-VEGF be preferred? And what evidence support the use of focal thermal laser combined with? Yeah. Okay. So first question first. Yeah. So verteporfin PDT compared with anti-VEGF, it is typically used in polypoidal choroidal vasculopathy, and it is typically not used in other subtype of wet AMD, for example, CNV. It is not evidence-based. I have very occasionally used that. It is not evidence-based, and you have to tell your patient it's not evidence-based. Yeah. The second point is the red lesion. It is typically PDT resistant, so no point trying, because there were early papers of using for the combination therapy for red, and actually you don't need it. Red lesion mostly respond very nicely to monotherapy, anti-VEGF monotherapy. One point of important point is that the early days of verteporfin PDT was actually used for classic CNV, which is above Brooks membrane. But today, it is actually not a good idea to use verteporfin PDT for classic CNV. Yeah, and the trials that tell you very clearly that it is not advantageous to use PDT. And classic CNV or type 2 CNV actually respond very well to anti-VEGF treatment. And if you PDT those lesions, that's where you get a lot of exudative response, and then later scar formation. And some of the concern about verteporfin induced disciform scar is actually lasering, irradiating using PDT for classic CNV that were confused with polypoidal, because some classic CNV, if you image with ICG, actually looks like polypoidal. So it's very important to actually, before you do PDT, have a double check with the OCT, right? See, oh, polypoidal, PDT. But if you check with OCT, actually, those lesions are above RP, and don't use PDT for those cases. Yeah. Now, what evidence support the use of focal thermal laser combined with anti-VEGF? So first, focal laser for treatment of polypoidal, etc., there's only the benefit of K-series. There's actually no evidence of combination with anti-VEGF treatment. So if you use it, you have to tell the patient this is off-label way of using treatment. But I have had, cases, unfortunate cases, where you do thermal laser, and the next moment you see the laser-induced CNV. Yeah, so I'm being quite careful to use fairly light laser, only mild to moderate, and then if necessary, just repeat. And if I find that the lesion is quite large, I actually combine with anti-VEGF treatment. This is off-label, no evidence. Next, what alternative therapeutic modality exists for managing ocular hypertension and optic neuropathy in resource-limited setting devoid of advanced laser technique? Yeah. So for optic neuropathy, I think that would be a separate talk. And for likewise for ocular hypertension, most of the time the IOP lowering agent that would be the key, right? And filtration surgery, etc. Right? Okay, so what is the update on treatment for GA? Yeah. So GA, as you know, complement factor, factor 3 and factor 5, anti-complement factor 3 and factor 5 treatment they are now available. In some countries, they are approved. Some countries, they are pending approval. Some countries, they are not approved. Need multiple injections with about 20% plus effect on reduction of the GA growth. So it's considered controversial in some setting. It's important that the patient know that there is treatment. Right? Because if you don't tell the patient, then the patient say, "Oh no, you never told me. Now I'm having GA, my phobia is wiped out. You never tell me." Yeah, I think it's important to have the chance to discuss with the patient that there are treatment. Now, I think there are some other emerging photomodulation based treatment. We are actively watching this space. I think we hope that they have more and more modality. And I believe that first in human cell injection, subretinal injection cells. So that is not my area of forte, so I can't say anything intelligent about it. Next question. A good question for this topic is how can integrating multimodal retinal imaging technique improve early diagnosis, monitoring, and management of retina compared to using a single model? Okay, that's a very good suggestion. Thank you. From Samar, good evening to you. The question is on the resource limited setting where having different imaging modalities is not possible. What would be the 2 or 3 imaging modalities that you definitely would be useful for treatment of wet AMD and PCV? I would go by first OCT, and then stack on it ICG. So FA, I guess it comes with ICG machine. Most of ICG machine would have FA. So if you have FA, ICG, and OC, that probably would be quite sufficient. From Arif, which specific modalities such as optical cohesion, fundus autofluorescent, infrared provide the highest diagnostic yield for detecting early structural damage when baseline historical data is sent? Okay, so structural damage, I guess you mean EZ disruption, for example, RPE changes, RPE atrophy, and all that. I think OCT, if you have one modality, it's still OCT, right? Because OCT, if you do dense scan, you can construct on fast, you can see atrophy. Yeah, and OCT, you can see EZ disruption, you can see all the changes for structural damage from the photoreceptor RPE, all the signs that are described by Chem group. So next question, Diego. We are 5 minutes past time, so I will scroll down as much as I can, answer as many as we can. If it's time's up for you, please feel free to log off. Question from Diego. My name is from Chile. Hey, hi, Diego. Want to know if there's high risk sign of visual acuity loss over time in wet and polypoidal disease. Yeah, so in terms of high risk sign, in PCV, polypoidal disease, it is actually quite difficult to predict. Yeah, but of course, if you have thick blood underneath the fovea, you have a very thick scar in the subfoveal region, you have loss of EZ band, and you have loss of RPE reflection. All these are signs that visual acuity is going to be badly affected. Next question is burnout. Is from Muhammad Mokhtar. Hi, burnout diabetic eye disease. Okay, scrolling down again. Burnout diabetic eye disease show this neovascularization regression of the PRP, but new vicious hemorrhage occur 6 months later. What imaging would you prioritize before retracting? Okay, so in those cases, right, once you have neovascularization of the retina, even after PRP, you'll find that much of the vessels remain, right? Of course, they regress, but they don't really resolve, right? So you still have vasculature there. Of course, they are less vascular and less prone to bleed. But recurrence bleed is actually quite common. So those cases actually can be treated with anti-VEGF without much additional need to image, right? But a careful fundus examination is quite important to detect those vasculature. And of course, if it's already bled, then you can't see the vasculature, you should do ultrasound scan to see whether there's any traction of the macula, whether there's macular detachment, and then you manage accordingly. Now, many of these patients would do very well with anti-VEGF injection. The issue of VEGF crunch syndrome, where there's aggressive change of the retina tissue into fibrotic tissue and then traction retinal detachment, I think it's a bit overrated. I for one would just give anti-VEGF, but I would tell the patient for the first jab, I will see you in a week's time, and if vision drop before a week, come back straight away, because 4% of cases get VEGF crunch syndrome. Yeah, and if it occurs, you just take the patient to OR. Okay, next question. Would micropulse laser be effective for CSR? Yes, I think micropulse work very well for CSCR. Just that I have more sort of experience with the verteporfin half dose, and yes, there's no issue with using micropulse. It's worked very well. Next question for Martin. From an infectious disease perspective, how can multimodal imaging help distinguish active viral retinitis from inactive light-activated therapy, reduce scarring, and lower eye pressure better than traditional thermal burn in advanced long-term glaucoma? Oh, wrong. I think I must have skipped the question. Okay, I'll go back to Mahin, sorry. From infectious disease perspective, how can multimodal retinal imaging help distinguish active viral retinitis from inactive post-treatment lesion? And how can these imaging finding be integrated with ocular fluid CPR? Okay, so for viral retinitis, actually a lot of this is clinical diagnosis and follow-up color fundus photography if you have enough clarity of your lesion. Of course, you can do FA to look at the degree of leakage. However, in the atrophic cases, you would also see quite a lot of window defect, and sometimes can be confused with hyperfluorescence due to leakage. I find that for monitoring of viral retinitis, careful examination and have baseline photo and then sequential photo, I feel it works very well to guide antiviral treatment. So Arif, answer question please. Sorry, I think it jumped. Okay, it jumped to, okay, does combining non-thermal laser with light-activated therapy reduce scarring and lower eye pressure better than traditional thermal burn in long-term glaucoma cases? Yeah, so I think you're asking whether thermal laser is used for treating glaucoma cases. Yeah, so I think this is outside the scope of this particular talk. We're focusing a lot on fundus imaging in terms of macular imaging, treating retinal condition. So for long-term glaucoma cases, the treatment is drop, stent, filtration, etc. So you can use selective laser SLT, but I think it's beyond the scope of this talk. Okay, I'm going to move down to the next. Okay, I think I have answered most of this. Yeah, because drainage angle and all that is beyond the scope of macular imaging, obviously. Okay, so I'm afraid I can't help you with that. Then I'll probably go for the last question. It's already 10:12. And last question from Mostak, Mr. Mohammed Mostar. A patient with wet AMD showed OCT confirmed fluid resolution after anti-VEGF, but no visual improvement. Yeah, what imaging step must you take before labeling this treatment failure? Okay, so there are various things that you can do and see, right? So, of course, it depends on how long this patient had fluid and whether the EZ band is already lost. Yeah, so if the patient had very chronic fluid, obviously, even if you dry it up, it doesn't work, the vision doesn't come back. The important point is paradoxical response. So there are patients with subretinal fluid resolution, and yet vision drop actually. So it occurs in a small percentage of patients, especially if the patient have had the condition for many years. There are patients with SRF or subretinal fluid that are considered compensatory, right? So the type 1 CNV in some cases can be compensatory in nature. They produce a bit of subretinal fluid which nourishes the photoreceptor, and if you dry up the subretinal fluid, instead of visual improvement, actually you can have a sudden drop in vision. That's quite well described. So the important part of management of these cases are the following. Number one, you will need to make sure there are no other causes of decreased vision, such as cornea, opacity, cataract, etc. The second point is that do refraction as many times as you can, meaning do best corrected visual acuity if you have cases like this. Because sometimes when you inject and then vision drop, you don't know whether it's because uncorrected visual error or what, right? So uncorrected refractive error. But if you have best corrected vision on most of the visit, if not every visit, then you can detect a very slight drop. One line, two lines, say, hey, something is not right. Better check again, repeat refraction, and it's indeed drop. These are the cases I would really hold off injection. So I defer by 2 weeks. And many a time, the vision come back after deferring for a while. But not easy to manage these cases because the treatment strategy for this is not well published and not well studied. And there are many variation, right? Variability, of the visual acuity for a patient with wet AMD. So if the patient happen to look at some bright light just before doing visual acuity check, the patient can have palinopsia or this delayed photo recovery, and then you register a drop in vision. So there are various reasons why a person could show a lack of visual improvement, although structurally the fluid is gone. Okay, so I hope I've answered to your satisfaction. There are any other questions, feel free to email to Cybersite. And for the questions in glaucoma, so sorry, I'm not a glaucoma expert, so I wouldn't do justice trying to answer them. Okay, any other question? Yeah, if not, I wish everyone a very good day, good night, good evening, wherever you are. And if you do multimodal imaging, have fun looking at the images, and I think you will discover a lot by comparing imaging modality from one to another, and I think you'll see and you'll learn more and more as you spend some time every day, just 15 minutes to look at one case, right? One patient, and compare the different modality across. Over time,